get your questions answered. This is the adult version. So this time we're going to be answering questions about symptomatic men and women. So this is our opportunity, patients. This is what we always dreamed would happen. We have the opportunity to ask any question. No question too big or too small. Anyone want to start it off? I know we have some that are online. Yes. I'm coming. Look how fast I am.
Hi, I had a question about the neurofilament testing that Dr. Lund, you had spoken about that yesterday, but in the pediatric population. But I was wondering if you could speak to like how it would relate or be helpful in the adult population and then actually specifically in women. I know it's been being drawn on me and not really discussed too much further. It's just like you see a result in the portal.
Yeah, I think for certain people have a baseline level. Should they develop blood-brain barrier disruption, that is active cerebral disease, it'll go up by a magnitude. So it'll go up by 75%. So I think that's the value of it. And that could be a man with AMN who's being followed longitudinally, being at risk for developing cerebral disease, neurofilament light chain would increase dramatically. I imagine the same thing is true for women too, but the cases of cerebral disease in women are so extremely rare, I'm not sure how we'd actually prove it.
I think there's elevations in NFL at baseline for peripheral neuropathies as well as the spastic paraparesis. So it's not going. Sorry, I don't think it's going to just represent the cerebral disease, that there's going to be an elevation in spastic paraparesis and peripheral neuropathy in adults, that we don't see that in the baseline in the normal children before they manifest adrenal disease. So the baseline is going to be a lot more wobbly. I think Dr. Fine probably.
It's a good. I'm actually not as familiar with the literature and other in other peripheral neuropathies or spinal cord injury. I think it's an important point that, as we know, it's the adrenal insufficiency. There's the spinal cord aspect and the peripheral neuropathy aspect. So I'm definitely not an expert in literature. I don't know if anybody in the stage is, and other conditions, but I think it's definitely a valid thing as we're considering, long-term what the monitoring means, especially outside of this more clear-cut context of, cerebral inflammation, blood-brain barrier change, this major event. If we think that it might be more useful for long-term monitoring or prognosis, all of those nuances are going to need to be considered.
There's a paper out by Johannes Berger and Isabel Weinhofer, and they published on this looking at NFL levels across the different phenotypes, and they do discriminate. So for the patients and families in the room, you don't have to read the paper, but the graphs are pretty clear.
Was that repeated measuring?
No, there were some with repeated measurements. Yeah.
Okay. Oh, on my way. Or Brittany.
Thank you. Hi, I've got two questions, slightly linked. So Dr. Eichler spoke yesterday about X skewing inactivation and reactivation. He was talking about it being done in early development stages. I wondered if that meant that you could only look at reactivation at kind of infant phase, or if that's something that can be looked at in early adulthood, kind of before symptoms have progressed too much. And slightly linked to that, I was wondering, with the new cohort of young kind of pre-symptomatic adults that are being identified through newborn screening, is there any opportunity there for research to be done? For example, natural history studies, including more young people, so that we can find out when symptoms develop and what symptoms develop first, things like that, or anything to do with disease prevention.
Yeah, so to the first question, so full disclosure, I'm not a geneticist, but Dr. Eichler was referring to, the degree of symptomatology seems to be linked to how far you skew towards the mutated X versus the X that's okay. I don't know when that happens in development, and I don't know. Yeah, but and it doesn't change. Yeah, but I don't know about therapies if there are therapies available for skewing in the other direction. I'm not aware. Yeah.
Okay.
People are trying. I have heard of attempts to re-skew or redistribute the X, but I'm not so sure if that's a kind of a scary idea. I think
Yeah.
because you don't know what the outcome will be. It is rolling dice.
It's-
Referring to X inactivation and disease severity in women, there are 6-7 described cases in literature, and the ones I know about, all these women, that whole body, every cell had the diseased ALD gene. So technically, from an ALD perspective, from a biochemical perspective, you could see that these women behaved like males, because there were no cells in the body that had the normal gene.
In your and Mark's paper, you did not find a correlation in the larger cohort of 49 females between the degree of skewing, the percentage of skewing, and the severity or onset of symptoms of the myeloneuropathy.
That's true. We do see a correlation between the X inactivation in the blood and the biochemistry. And there's no clear correlation indeed between if you have 40-60 or 70-30 and severity, but there's very clear correlation between 100 and the chance for cerebral ALD, or below 30 of the disease percentage of cells that have the diseased gene, and 70% of your body having the normal thing, and having very mild phenotypes. We even had a female that had completely normal biochemistry, and we found her because she was a sister for other adult women. So I'm not sure if it answers all your questions, but
Sorry. So I was going to throw in one thing about profound X inactivation skewing is often it can be an indication there is something else going on in your genome, like an autosome to X chromosome translocation or a deletion that's involved in the imprinting. So sometimes disease severity may be a larger phenomenon, and that could be potentially linked to other things or the severity. So it is really rare for someone to be completely X inactivation skewed to just one X chromosome. And if there is, you have to question, is there something else going on?
Yeah, I also remain very interested in X inactivation from hematology point of view, where it was a large part of what we know about it was originally described in a blood disease called G6PD deficiency, discovered by Ernest Beutler in the 1960s, and that led to some of the discoveries in X inactivation. But since that time, people have been trying to figure out how to inactivate the X, and I don't believe there's really been much progress in trying to figure it out. It's not even clear how it gets activated, inactivated.
And just to add to that as well, the therapies that are under investigation for X reactivation are not long-term therapies. So it's more of we're temporarily reactivating that part of the X chromosome so that the ABCD1 RNA and therefore the ABCD1 protein can be made. But this would require frequent infusions, and so it's not like you're permanently returning it back on.
And to my question about the research opportunities with the kind of new cohort of newborn screening people, like I say, I've grown up knowing about ALD, that I have ALD. I'm 24. There's a lot of other people now that are being brought on because they've had children at, maybe 21, 22 years old, or anything up to 30. To me, this seems like a really exciting time, I guess, because all of these people are pre-symptomatic, possibly. Do you feel that there's any opportunities there for research?
No, I think absolutely. I talked at the women's group. I didn't want to make any promises as to like anything that we're actively doing right now. We're just in the kind of planning and ideas phase. But I think having pre-symptomatic women and then kind of doing the frequent physical exams and then kind of seeing the point in which you start to develop myeloneuropathy symptoms, that might be kind of the thought process that we have for when you'd want to pull the trigger on starting therapies in the future. But as of now, obviously, there's nothing is in the pipeline that can actually be given to patients right now.
True. Oh, yeah. Sorry. Crosstalk. So I think so. Ali had wanted me to sort of mention the point that we are at Kennedy Krieger, and then also with a couple of international cohorts, like really trying to delve more into deep, I guess you could say sort of deeper phenotyping for both men and women in terms of trying, like Dr. Thompson was mentioning, trying to figure out if we have enough asymptomatic people in the cohort that we can kind of really measure the threshold at which symptoms develop, even if, I think ideally, even if it's not perceptible to the patient yet, and so we have like our clinical scale. So this is actually not a conversation we had, I don't think, at all this weekend, but there's like the EDSS, or this expanded disability scale score. Many of you might be kind of familiar from the clinic or from research studies you've participated in, and so we have these wide scales, but it really takes a lot in terms of disability change or new symptoms to arise for you to get a half a point or a point change on that scale. So like that's again why we sort of do testing with the force plate or things like the 6-minute walk test, or using wearables to even try to find other subtle variables having to do with mobility that might like help us to track that change. And and then we're sort of actively also putting forth grants that help us to try to like look at that profile in detail, see how that lines up with spinal cord white matter changes. And I think there's sort of really a push to understand how this process might be different in women and to ask new questions. And some of that might incorporate not trying to change anything about X inactivation, but maybe at least have that as a baseline factor that we're aware of. So when we look at these super detailed phenotyping profiles, we also have a sense of what's the gene variant and possibly also kind of where we stand for the women with the X inactivation level. So yeah, it's coming down the pike.
I have an online question, or one that was submitted in advance. Why do some symptomatic women with ALD have movement disorders or dystonia, but AMN men do not?
I disagree with the entire question. So, so it is not true that none of the men have dystonia. Okay, I don't know. And when you go to a movement disorder conference, and I was at one last week. I was at the American Academy of Cerebral Palsy conference, which is focused on pediatric cerebral palsy population. And you sit there in a room with 200-300 neurologists that are our movement disorder experts. They will 59% of the time, this has been studied, not agree whether they would call a certain position dystonia versus spasticity. Okay, so I think we shouldn't get stuck on these and have these type of discussions, because it's like we are basically like defining terms. We can't agree what we call these terms, and then we would be arguing why do women have this versus men don't have. That's my opinion. So I don't think this is a good question to be asked. I'm sorry. What I would say is that we have seen some symptoms or signs in women that we find rare in men, and that is rare in women also, okay? And so, but it seems to be a little more common in women than in men. For example, one of the things that we have seen is there tends to be what we call a slight torticollis, a slight turning of the head, of the neck, I guess. There is some people who have mild, what we call bobbing of the head, a little bit of a bobbing of the head, very subtle. There are some people that have a tremor. And so we see these things rarely in women, but we see it more than we see it in men. Okay, but there are a few guys that have that too. But I don't want to go into the conversation of dystonia versus spasticity, because this really, I mean, you have another neurologist here. You can provide your opinion about it.
I throw up my hands. I try the experiment, and I try baclofen and see what happens. I try dopamine, I see what happens. And frankly, I use the clinical responses helping me figure that out, because I don't think it is always clear.
And it's usually, these are human defined terms and not biologically defined terms. And so you'll actually, more important is, I think, whether there's a response to the medication or not.
Hi. I just had a question that we didn't talk much about in the last couple of days, but it was about mosaicism. And I just wanted to know, is that kind of, how does that fit in the pattern of like hereditary? I think someone mentioned earlier, it's like a Christmas tree lighting up when you find out about a diagnosis. And so trying to understand how to interpret, potentially negative results, and is there a concern that there could be this mosaic possibility as well, and is that something that people should be concerned about if they get a negative and their family is lighting up on that Christmas tree?
Are you talking about the context of a boy or a woman, a symptomatic female? It's a really good question. So for symptomatic females, the X inactivation is a normal process because your cells don't actually want to see both copies of the X chromosome. So every single woman will have just one of those inactivated and one activated per cell. So that is mosaicism, but that's different in the context you think about mosaicism for in other diseases. So are you saying if you have a boy with a negative genetic test, but there's family history of ALD, that could there be mosaicism going on? Okay. So for women, when you do a genetic test, you do it on a blood cell, right? And so it is possible for ALD and other disorders as well that the blood cells are not affected with ALD and yet other cells in the body are. But in the case of ALD, it's the kind of more central question is, which of the X chromosomes that you have when you were the sperm and the egg fused originally, there was an abnormal copy of ABCD1 on one X chromosome and then a normal X chromosome, and the degree to which your cells in the totality of your body decided to manifest one or the other is what we think might correlate with symptoms, although it's still to be determined.
I probably should hand this over to our genetic counselor.
It's much warmer here too than in the back. I think I'm going to hang up here. That's lower. I think I also heard you ask about mosaicism and inherited. Yeah, so this is kind of it can be a hard concept to get around. So mosaicism, that person could, if someone themselves is mosaic. So mosaicism means a combination of cells with the variant and totally normal cells. So a person who is mosaic, they can pass it on to their children if that mosaicism is in what we say germ cells, which doesn't sound very nice, but eggs or sperm. But if a woman is mosaic for the variant or a boy, they wouldn't have inherited it from their parents. What happens new in them? Did that answer that part of your question? Yeah. Okay. What didn't we answer?
Well, I guess the question is just that, like, if you test negative, right, as a woman whose family has
Okay.
How confident are you in that result?
Thank you for clarifying. That is, yes. So if you have a family history of ALD and then you yourself test negative, you don't have it. So someone who is non-mosaic, like most folks, if they pass it on, that son or daughter has it in every cell in their body. So you can be confident in a negative genetic test result.
I think the thing that we use the same word in two different contexts. So mosaic basically means a quilt of a difference in a particular thing. In one case, X inactivation, and in another, which cells have a gene. And the way I think of it is, if your mom or your dad is has the gene, and you either inherit it or not. It's that coin toss discussion. But if you don't have anyone, neither your mom nor your dad had the gene to pass on, but you have de novo gotten a new copy, that's something that happened in the eggs or the sperm as they met. So they're in all of your cells in a de novo case. But a mosaic, I think of as you developed a little bit and then your DNA made a mistake. And then some of the cells, but not all, make the quilt of your body. And if that part of the quilt is your eggs or your sperm, then you can pass it on. But if your parents have that gene to give to you, you aren't going to be mosaic. It's going to be, as we say, Mendelian, the coin toss.
You didn't exactly ask this, but I want to throw in one more thing about mosaicism is germline mosaicism. Has anyone heard of that? So, okay, we got some people there. So they were talking about de novo variants, which happen new in an individual. So if your son has an ABCD1 variant, but you test negative, there's still a small chance of having another child with ALD because that new variant could be just in your egg cells or just in your sperm cells. So I still encourage, so you still can think about testing other siblings, but you wouldn't need to test in generations above.
I have a follow-up question around cervical dystonia. I'm one of the women who has titubation and pulling. And when we talk about AMN in women, we typically talk about it as a spinal cord disease. So I was curious what the pathology is for whether it's dystonia, spasticity, or is it happening in the brain? Is it happening in the spinal cord? In women specifically.
Why is Dr. Eichler always missing in action when the questions are things that he caused trouble with? So I'm going to pretend to be Florian Eichler. So we published the paper. No, so they actually... so this is a very good question in terms of, okay, so if we are indeed seeing symptoms in a subset of patients that are not typically explained by spinal cord anatomy and physiology, how do we explain it? And again, I'm a little in disagreement. I'm actually strongly in disagreement that this is extremely unique just to women. Okay, I'm going to say that, and I also think that it's rarer in the larger population than I think it's been sort of reported by the Boston group. It might be that there is some sort of a sampling issue there. We talk about the rare disease, so obviously it could be the case. It could also be an observational skewing, right? So again, when you have a movement disorder looking at a kid and a non-movement disorder looking at a kid, they're more likely to use different terms for the same abnormalities. So that's just so we are on the same page there. But they did do a study, really very recently published a study looking at where is the ABCD1 gene expressed in the brain in terms of the neurons. And one of the regions that's we see actually high levels of expression is part of the basal ganglia system in the mouse, which would imply that ABCD1 doesn't just play an important role in the, we right now think of it as a, cerebral ALD, sort of a microglial macrophage type of disease or an endothelial cell disease. And we think of the AMN as a long-tract axonopathy. Hugo Moser always used to say it's a long tracts that go up and down your spinal cord, which is very true. But there seems to be also a role for ABCD1 in parts of the basal ganglia system that might be critical to its function. And so that's as far as we have gotten so far. Now, it wouldn't explain at all why we would see this in females more than in males, because the burden in terms of the disease burden based on the gene dose would still be much higher in males. But that's the complexity in nature, is that there is usually what we call like a canonical function of a gene. So the canonical function is defined as the function of the gene that we think its primary role. So in ABCD1, we know its primary role is to transport these fats into the peroxisome, right, that you saw. Could it have other non-canonical functions that are dose dependent, and perhaps only in a certain dose range you will experience symptoms, but not if it's completely absent or not? We don't know, because we don't know exactly what it's interacting with. That's still to be defined and all that. So I think there's a lot of complexities there, but the bottom line is that those symptoms that you mentioned are not explained by the known spinal cord anatomy. So that just implies there's something else going on. And it could be the basal ganglia. It could also be the hindbrain, the cerebellum. We know, for example, in other peroxisomal disorders, the peroxisomal biogenesis disorders that are usually much more severe, they tend to have very, very pronounced cerebellar involvement. And the interesting thing is, those are the Zellweger syndrome kids. They were the really severe neonates. We call them neonatal ALD form and so on. But now we are finding, as we're doing exome sequencing, that there is all these individuals out there that actually don't have Zellwegers, don't have neonatal ALD, are in fact normal, typical sometimes in the initial development, but then develop a cerebellar ataxia picture and yet are having a peroxisome disorder. And so I think there is something cooking there that we need to understand, but we don't understand the mechanisms yet. It's just this paper. There's this only one paper that just came out. Was it this year or maybe late last year, by Florian's group, that found this ABCD1 expression to be high in certain areas of the basal ganglia in the brain. So I'm sorry, there's no answer, basically. Long story short.
So, and just to add one thing, this kind of goes back to the research question, and I was having a conversation yesterday with one of my old patients, is amongst your groups and when you guys meet and talk, I think it's really important, especially for the women, to really share the experiences you're having clinically, because that teaches us what to look for in natural history and the differentiation between men and women, and what we're looking at and thinking about natural history and then hopefully treatment trials down the line. The more we understand the woman's experience, the female experience with ALD, the better we can measure it, give us more precision, and increase the chances that, say, a drug that gets tried, we can test it across all these variables, and the more variables we have, the better.
Back to the mosaic. My mom and dad both tested negative, and me and my older sister both tested positive. My third sister negative. The baby will not be tested. So they told us that one of my parents is mosaic. We had really assumed that it was my mom because 2 out of the 4 of us. But from what you're saying, it very well could have been my dad's sperm, even with 2 out of 4 of us.
Just a question. I don't know much about de novo women. I am not one. Our mother has this, but is there extra testing, and are you watching MRIs and that group of women more closely?
So the question is based on de novo versus, there's really, I don't think at this stage there's any reason to screen or treat or test them any differently.
I might be possibly what's implied. I don't know if you were maybe implying that. Were you asking about monitoring de novo inheritance folks because there's less family history to rely?
And what you spoke about how their cells, or all of them, are the bad strain, the mutant strain, that their body would be more full of this?
No, there's and I had also just wanted to make sure that there wasn't a sense that people follow like the trajectory of their family members. Like it can be very, even with the same variant, Each case is so individual in terms of progression. But yeah, as was already said, like there's not anything different that we can expect about the clinical course, the outcomes, which phenotype of ALD it'll be, even with a brand new variant.
I think a question is not only about the de novo cases, but also, more relevantly to the variants of uncertain significance of the importance of the clinical exam, not going straight to the imaging, but doing an exam, because there is the possibility in a variant of uncertain significance that it is one of the ones that's a benign but different spelling, but not disease causing, that there could be some other reason for symptoms that shouldn't be missed. And so I think seeing your doctor, explaining what your individual symptoms are, getting a good clinical exam, and then if imaging makes sense, then you do imaging, is a good start. And I don't want to take out the clinical eyeballs from the equation.
And also, just to clarify, if it's a de novo change, it doesn't mean that you're skewing all the way in the direction of the abnormal copy. It's different. It means that your mom and your dad did not have ALD, and in the process of the sperm or the egg forming, there was that new change. So it means it comes from a parent that was not affected, but then you still have one X chromosome that has an abnormal copy, one X chromosome that's normal, and then the degree of X inactivation is what determines the risk for symptoms. Does that help?
Yeah.
Okay.
Yeah. And you talked about, so there's no, I guess it's always like the question of not waiting for what's going to happen. It's interesting to hear, and all of us that have it are like, well, which end do we skew on?
You can test for that.
Yeah.
We do in Dr. Eichler's clinic.
Great.
I had a question. I was wondering, we know that neurologically we can, peripheral neuropathy, we can have burning, we can have feeling cold, we can have pain or numbness. Do you see a lot of really itchy people? Because this came up recently on the women's call and people were saying, is this from ALD? Is this our experience, or is that just something special that people are working with?
So itch is a really... Oh, sorry. I'm Jacinda Sampson. I'm a neurologist and a neurogeneticist, mostly adult, from Stanford. Anyway, itch is neurologically very interesting. It works on the same pathways as pain, burning, tingling, the small fiber entities. So often the same treatments that we use for those other what we call positive symptoms, which is if you look at a nerve function, it would be normal, or it doesn't function and you have numbness, or it gives you wrong functional information like burning, pain, tingling, pins and needles, sometimes itching. Those positive symptoms can respond to medication, but for itching, you should always just make sure it's not a dermatologic problem. Allergy, contact allergies, some other skin finding, look into the normal things, the common things being common, because that would be a different therapeutic approach. I'd hate to treat your eczema with gabapentin, for example. So I think, again, having someone look at your skin and see, is there some reason for itch?
Can I just add something about the itching? It's right here. Over the past probably 18 months, my forearms, my hands, sometimes will be extremely itchy where I'm like, I just want to claw the skin off them. The dermis will thicken after I've scratched it. And I did see a dermatologist, and she said, most often we're finding that's coming from your neck. It's like, oh, good. So, I don't know. I'll go a few weeks with maybe it won't bother me, and then I might go the next 6 weeks and I'm just miserable. So, I don't know.
I think this sort of goes back to a principle that we talked about earlier too. Like, well, first things I agree with Dr. Sampson, like common things being common, you know, making sure it's not a skin condition. Also, sometimes like side effects of medication can cause itchiness, so making sure to kind of review it for. I don't think that's the case for you. I will say I don't think I've had that complaint from a woman with ALD, but for a couple of other adult leukodystrophies, we have done the test of okay, clearly we've ruled out all these other common things. Let's assume it's another neuropathic, another change related to what's happening with the nerve fibers. When we test maybe with gabapentin, and there was a response. So like that. So the principle is like, let's just test it. Like let's treat it as though it's like, a nerve-related symptom. And if you try that medication and it improves it, fantastic. We sort of like proven the link.
Yeah, I've been on gabapentin for, I don't know, 20 years, probably.
Yeah.
And that's mostly for the leg cramps.
Mm-hmm. Sorry.
Hi, my question is, have any of you seen any patients that are pretty asymptomatic, that maybe their job, a very physical job, exacerbated or triggered symptoms to begin? Well, like something where you're walking a lot or very stressful or anything.
I don't think that we have ever seen anybody sort of get. In fact, I think it's the reverse. My notion has always been that the men and women who do a lot of exercise and are very active physically tend to be less affected or perhaps even progress slower. There was a study that Jen Keller did. She's still here, right? Or did she leave? Yeah. Jen, you want to talk about your exercise study for a second?
Sorry.
The women's curve study? Yeah.
So we found that in women who did a curves exercise program for 3 times a week for 12 weeks, that they actually had a sort of reduction of how much pain affected their quality of life, and they improved in their strength as much as healthy controls did. So they actually saw quite a bit of benefit. They walked faster, which is our classic indicator of some improvement. So we've seen more benefit from exercise than people finding problems with it, I would say.
I think maybe to be specific would be like walking, like in jails. Like my husband's a deputy and he had no symptoms. And then after he worked almost 6 years in the jail, horrible shoes, walking every single day, 12 to 16 hours. So I was just wondering if that...
I don't think that the walking made the disease worse.
I think if I can just add is that, when you have weakness and sensory changes, it changes your walking pattern. And so like being, you can basically develop like secondary, symptoms like you would just from having like a work. If you have people get carpal tunnel from tons of, repeated wrist exercises or something like that. But that's more of just a situational problem that happens because of the activity that you're doing and not necessarily because of the, underlying disease. It's sort of an associated pattern.
Hi, this is really a follow-up, I guess, on that. And I'm hoping for a good response. My daughter does exercise at an elite level, and I think she would be thrilled to hear that you have never had a patient come to you with ALD or AMN symptoms who is an elite fitness person.
Sorry. I don't think that's what you meant.
No, that's not what I said. No, what I'm saying is our sense is, and this is not studied beyond Jen Keller's research that she just described, our sense is that individuals who are physically active are actually less likely to be severely affected. Okay, so less likely doesn't mean that if you do exercise, you'll not have the disease. Okay, that's unfortunately not the case. That would be awesome, but that's not the case.
I have a related question,
Yeah.
I think. Does lower body fat percentage correlate with lower lipid, very long chain fatty acid levels, and has this been studied? Maybe not related.
You were grabbing the mic.
You should talk.
It has not been studied, but we also don't have any indication of that being effective. I hear somebody?
No, I was going to make a comment about the last question.
Oh, okay.
So in the AMN, the N part, the neuropathy, does cause structural changes in the muscle mass in your feet and lower legs that can change your foot architecture. And so it can lead to, kind of an architectural change in the arch of your foot and more easily getting foot pain. And some of this can be addressed with orthotics, ankle fixation orthoses, things like that can help with reducing that secondary pain in your feet and legs from the structural changes happening from the neuropathy. So I wouldn't say that there's no effect of, standing and walking, but I think it's your body reacting to the changes that the neuropathy has already caused in your feet with their structure.
I know we talk a lot about neuropathy and the standard of care is gabapentin. Is there any studies showing that like pregabalin, like Lyrica, might actually be more effective in treating neuropathy with ALD, or is that really like a physician choice, especially if someone is kind of hitting the tolerance with gabapentin?
Again, I don't think there have been any head-to-head trials. They're mechanistically very similar. They're chemically cousins. Gabapentin has been around longer, is generic and less expensive, so often we start with that. But if people aren't responding, there are other medications we can change or switch to, Lyrica being one of those, duloxetine being another. So there are other options, but all of these help modulate the pain. None of them, and they take time to have an effect. You got to give it a few weeks. But none of them are like 100% pain relieving. So it's a balance of side effects and effects often.
I have an AI question. Do you recommend a calcium supplement for adrenal insufficiency?
Well, there's nothing specific about providing calcium supplement. I think that if the question is trying to prevent bone decline, we normally recommend calcium intake in patients. There's no good data in men, whereas in postmenopausal women we aim for 1,200 milligrams in a day to maintain bone density. But in premenopausal is about 1,000 milligrams when we extrapolate that a little bit to maintain a healthy diet. So calcium from the diet is better than a calcium from a supplement. If you can increase your calcium intake from your diet, that's better absorbed and that's have almost no side effects. Whereas the supplements, they can lead some of them to constipation, among other things. But yes, in general, having a good calcium intake would be healthy, but nothing specifically for adrenal insufficiency. In fact, some patients with adrenal insufficiency, one of the clinical findings is hypercalcemia. So that's a clinical clue of adrenal insufficiency in the setting of untreated adrenal insufficiency.
Thank you.
I had another AI question. We've navigated a few adrenal crises, and typically what we've done, several, you've had a few. He usually will like take a bunch of extra cortisone orally, and I'll get him to the emergency room. But it sounded like, I mean, we do have the emergency dose. It sounds like I should be giving him that shot and then going to the emergency room. So,
all right, if you can swallow, that's still good. The recommendation in theory is that intramuscular injection, which I kind of disagree because it's painful. Intramuscular injection is a painful injection to ask a patient to give it themselves or a caregiver to give it without training. So yes, anyways, you should be on your way to the emergency room while you're taking the pills.
So
yes. You should, but if you can't, then Yeah. Yeah. Well, you can call EMS and they can do it for you. Okay.
So you're running in the right direction
Sorry. So neurologists, we might recommend certainly that somebody would be a good candidate for Botox just based on our clinical experience and doing the same exam, right? Looking at the muscle groups, atrophy or weakness, looking at that balance with spasticity. So I could say yes, like I recommend this, but most of the time it's going to be a physiatrist or rehab medicine specialist. It's the same thing. It's interchangeable, who actually is certified to do the Botox injections and monitor you in clinic for that and repeat them if it's successful. Yep.
And just to be clear, physiatry and rehab medicine they're the same thing. It's just, I know it's a term that you don't hear often. You hear psychiatry, but physiatry. So these are people who are MD level physicians who have trained in rehab medicine to understand muscle kinematics and tightness and the therapy. Exactly, yeah.
I wanted to ask a question about the subject of fatigue in men with AMN, and whether or not, raising my son with ALD, I always felt it was my fault that he was tired because I hadn't done the medicine the right way. And I don't know if it's a medicine adjustment question or what are the best ways to address fatigue.
Maybe when they're all thinking of who's going to answer, I'd like to add something that to my answer to the previous question, because I was explaining all kind of missense variants, and I forgot to answer the question because those missense variants that result in unstable protein. We've done studies in which sometimes you can lower the temperature of the cells that you're growing. They normally grow at 37 degrees. But if you grow them at 30 degrees, then some of these variants, then suddenly the protein is there again, and it's functional then. Because it is not a functional mutant, it's a destabilizing mutant. And the variants that Rectify showed yesterday, I checked them, they're all, the 4 top ones that you were investigating, they're all destabilizing variants. So I think that's what you're aiming at in rescuing, yeah, so, thank you. So yes, so that's the approach they take. So they focus on the protein that is unstable, and if the therapy helps to make this protein stable again, and you get it into the proximal membrane, it's functional because then it's sitting there and it's just not unstable anymore. So I just wanted to add that, and you agree with that?
Yeah. Yes.
Okay, I think
now back to
question.
fatigue.
Yeah, so I can talk a little bit about the neurological piece of fatigue. Let me start by saying fatigue is not specific to ALD. Lots of neurological disorders, fatigue is present, and then when patients are really sleepy, we call them encephalopathic. It sort of changes their state of awareness. One of the most famous demyelinating disorders for fatigue is a big problem, is multiple sclerosis. So that's actually kind of one of the classical things you hear about. So I don't want you to blame yourself for how this is going or how it kind of went. It is in fact part of the disorder. We do give patients drugs to help treat their symptoms, and they can be sedating. But usually after becoming acclimatized to the drug, we hope that sedating effect sort of goes away. Kids sort of compensate for it over time. So that's the neuro piece. But I want you to know that I don't think we talk about it probably enough in the ALD field, but it's certainly present.
I just want to add from the endocrine perspective. So as long as the medicine or the hormone replacement is done at the right timing, fatigue shouldn't be present, but there are many reasons for fatigue. For example, one is adrenal insufficiency, mineralocorticoid deficiency, or aldosterone deficiency sometimes can lead to fatigue. So in case he's not taking Florinef, measuring renin aldosterone would be reasonable, and measuring testosterone also is reasonable because low testosterone can also be associated with fatigue. Now, something I forgot to mention, in young men and in kids planning for fertility, the decision about testosterone should be thought cautiously because testosterone decreased fertility because it suppressed LH-FSH and that suppressed intratesticular testosterone. So the planning family and all that has to be thought before starting testosterone. But those are reasons to have fatigue within endocrine. Of course, the neurological aspect, as mentioned, is very important.
So fatigue is such a complicated word. It's like pain. You know it when you feel it, but it's hard to describe it. So I try to break it down with my patients into what is the fatigue like? Is the fatigue sleepiness? Is it because you're waking up at night because you have to pee 5 times in the middle of the night because of your urinary symptoms? Do you have restless leg syndrome and that's keeping you awake? Are you on medications that are making you sleepy? Literally all medications I mentioned that are for neuropathic pain will make you feel more fatigued. Is it a decrease in endurance that you're spending a ton of energy just to stand and walk a certain distance? Is it emotional fatigue? Because often depression can manifest as inertia psychologically, which we call apathy, and also just other adrenal endocrine things like diabetes, low thyroid. All of these things can be factors. So sometimes just kind of like talking through what the fatigue is and what it is can help you sort that out. So things like energy conservation. You know, I want to have that energy to go out to dinner with my family, so I'm going to use a scooter instead of, so I can go longer distances and I have the energy to, get through dinner without being exhausted, or ways of looking at things.
That's all I was going to say too. Sorry.
So we're at about time.